Thank you so much for having me in the series. What I'm going to do today is I'm going to go through some of the data on ethnicity and the excess deaths that we seem to be seeing in certain communities in England during this COVID pandemic. And so I'm going to run quickly through a bunch of data that I've been collecting to try and understand what's been going on, and then try and think through some of the reasons to explain what we've been seeing. I should just introduce myself. My name is Miqdad Asaria. I'm Assistant Professorial Research Fellow at the Department for Health Policy at LSE, and most of my research focuses on health inequalities. So I've titled this Postcode versus Genetic Code, Ethnicity and Racism in the Time of COVID-19. And hopefully it'll become obvious why this is the title as we go through. And the kind of usual disclaimer that the data in this area is changing all the time, so you may not be able to reconstruct the exact results you're seeing here. Even when you're looking at historical data, the key administrative organizations are historically updating data as we go along and as they record things better. But I don't think that affects the conclusions that we're going to draw and the general patterns that we're going to see. So what do we know? There's a lot of anecdotal evidence that large numbers of people from ethnic minorities have been in hospital with COVID-19. And speaking to friends who are doctors in the NHS, they've been very surprised at how many patients they've been seeing from Black and Asian backgrounds. And we know that, and so there's this kind of rather clunky acronym, BAME, that's kind of become used in policy circles to group together Black, Asian, and minority ethnic communities. So BAME communities make up 14% of the population, of the English population. This is based on the last census in 2011. And if we look within the NHS, they make up 44% of doctors and 20% of nurses. And then when we look at deaths among doctors, we find that 95% of the doctors who died, this was up until 22nd of April, were from BAME communities. And 71% of the nurses who died, despite them only making up 20% of the NHS workforce, were from BAME communities. Other things that we started to notice very early on, areas that have the most COVID-19 deaths were more ethnically diverse areas. So looking at areas around London, and particularly Newham, Harrow, Brent, these are areas that are more than 50% non-white. And so looking at some of this geographical data more carefully, well, just to get an overview first, you can see darker red on this means more deaths. And so you can see there's a lot more deaths around London, Birmingham, Manchester. So big cities clearly have experienced this worse. And plotting this at local authority level, so here I've got cases at local authority level, and here I've got the percentage of population from BAME communities. And you can see that there's this kind of clear trend that we've got more cases in more ethnically diverse areas. And when we plot the data for deaths, it's almost even more stark that we've got more deaths in more ethnically diverse areas, right? And so some people, when they see this data, they say, this is just a London thing. The red dots are London, and you can see the red dots are all out to the kind of more ethnically diverse and more deaths. And so because this was happening earlier in London, that's why we're seeing this. It's just an artifact of how fast the disease is spreading. So we can split this data by London and non-Londoners. So these are age standardized deaths from the NHS. We look at the trend in London and we see even within London, as you get more ethnically diverse, you have more deaths. And outside London, you have the same kind of a pattern that as you get more ethnically diverse, you have more deaths. Okay? So we've seen some trends at this kind of national level and local authority level, but none of these dots tell us who's actually dying. It just tells us in areas where lots of non-white people live, lots of people are dying, but they could all be white people who are dying in these areas. So let's next turn to data from the NHS. In the NHS, they actually record what the ethnicity of the people who die. And there's two key data sets to look at within the NHS. One is the intensive care data from an organization called ICNARC, and the other is the actual hospital deaths data. So let's start first with the intensive care data. So ICNARC have put together this really useful data recording ethnicity of the people admitted for COVID-19 and so we can see that 66% of those admitted by the 30th of April were white, 15% were Asian, 11% were black, 2% were mixed, and 7% was of some other ethnicity. And they've put in quite an interesting comparator group. So they've looked at over the last 2 years, so between January 2017 and December 2019, what were the proportions of people who were in intensive care for viral pneumonia? So viral pneumonia you could think of as being perhaps as similar a disease as you could easily compare with in intensive care. And so they were looking at what, for a similar set of patients, what would we have expected to see? And so looking at historical data, they found actually 88% of their historical data showed of white people in intensive care, and many less in the other ethnicities. And if we just plot these as excess admissions, you can see that there's these huge excess admissions in each of the ethnic groups, except for the white ethnic group, where there's a lot less admissions than they would have seen for something like viral pneumonia, or than they would have expected to see for a disease like this. Next, let's start looking at some of the death data. And so one of the things that's become very clear about COVID is that it impacts older people much more. So this is just plotting deaths per million of population by age group. And so you can see per million people under the age of 20, about one has died so far. This is up until the 5th of May in the NHS data. And so the numbers are very small until you hit about age 60. And for people from 60 to 80, you can see this huge spike where it's almost 1,000 people per million are dying. And when you go over 80, then it goes even further. It goes 5 times as high. So it's almost 5,000 people dying at that age. And so you can see there's this massive age gradient in deaths from COVID. So if we look at populations by ethnicity, you can see this is the white population, this is Asians, this is black, mixed, and others, right? And I've broken these population structures, and these are taken from the 2011 census, into the age groups that we saw. And so the red bars are the age groups that are really high risk, so the 60 to 80-year-olds and the 80 plus. And you can see quite immediately from this that there's a lot more of those very high risk people in the white population than in any other ethnic group. And in fact, if you look more closely, and I'll circulate these slides so that you'll be able to look at these in more detail, because I know there's a lot of little writing on graphs to follow. You can see that more than a quarter of the white population is over 60, whereas less than 10% of the non-white population is over 60 in the country. So we could do something very simple and take these population structures, take the number of people in the population, and multiply through by the age at deaths to get a kind of indirectly standardized death rate, to get expected numbers of deaths in each of these populations, and compare them with the deaths that we're actually seeing. And doing that, we get this plot where we find that similarly to what we saw with the intensive care admissions, we observe a lot less deaths amongst the white population than we would expect to see, whereas we observe a lot more deaths in the other populations, in the other ethnicities, than we would expect to see given their age structure. And again, plotting these as excess deaths, we can see that there's huge excess deaths in Asian, Black, and other communities. You have to be a little bit careful with this other group because it's fairly small and it contains a very heterogeneous bunch of groups. And so, but overall, you can see the same kind of trend with less deaths than we would expect amongst the white community and more deaths in the other communities. And if you break it down even further, you can see that these are particularly concentrated in Pakistani, Bangladeshi, Black African, and other Black communities. Okay? And we'll see why that's important a little bit later on. And if you wanted to see the full breakdown, you can look at this in the slides afterwards if you like. And so what could be possible explanations for these trends that we're seeing? So how do we get more deaths from COVID? So there could be for three main reasons. The first is that we may have an increased number of cases in some communities. The second is that those cases may be more severe, and so if you get a case, you may be more likely to get it really badly. And the third is that there may be some differences in the treatments that different people are receiving for these cases, and so that changes their likelihood of surviving. And we can think about all of these factors, and we can think about how they might differ for each of the communities that we're thinking about. And maybe we can also start thinking about what can be done to mitigate these effects. So what I'm going to propose now is a set of hypotheses under each of these headings. And I'm not saying these are true. I'm just saying that these may be true and may be useful to research further to try and understand what's going on. So the first is the number of cases. So it may be the case that there's more exposure through employment in BAME communities. So we've already seen that there's more staff working in the NHS in BAME communities, and these are people who are continuously coming into contact with COVID patients. It may be the case that there are more people working in precarious jobs with 0-hour contracts. So they're the kind of people who would find it very difficult to be out of work and locked down, the kind of people who don't get sick pay or who are not on furlough and so have to go out to work. And the key frontline jobs, people like bus drivers, taxi drivers, people working in supermarkets, all of these people. So we can think about, are there more of these kind of people from BAME communities? And we'll look at some data on this a little bit further along. It could be something also to do with living conditions. If you live in a multi-generational household, if your house is small, if you're living in a high-density area, if you're more likely to be living in urban settings, you may be in closer proximity to somebody else who's got the disease and may be more likely to catch it. There may also be something to be said for the way the public health messaging and advice is communicated. Is it communicated in languages and mediums that are understood by all communities equally? Is the kind of recommendations made, are they suitable for all sorts of people living in all sorts of conditions? So that's also something to think about. Then we can turn to testing. I mean, testing overall has been a bit of a shambles so far, but you would expect testing in any kind of an epidemic to be linked to the prevalence or incidence of disease. And so if you're finding more disease in certain areas, then you'd expect to find, or in certain communities, you'd expect to be doing more testing in those communities. That would be an equitable testing strategy. So some or all of these factors combined would explain why BAME people might be finding it harder to successfully lock down, successfully isolate. And so going back to this kind of key epidemiological concept of the R value, or how fast or how much the disease is transmitting within different communities and areas, the R value for BAME communities may be higher than for other communities because of some of these factors. And it's important to note that if there's more cases, even if the severity or the treatment, the other two factors we were thinking about, are the same, we would expect more deaths, because deaths is a function of cases and severity and treatment. If any one of those three things is higher, we would expect to see more deaths. The next set of things we can think about is the severity. So there's been a lot of talk about increased severity in some groups because of increased prevalence of comorbidities, so things like CVD and diabetes. And we know there's evidence that there's more CVD and diabetes in BAME communities. There's been a suggestion that if you're living in overcrowded accommodation, then you might be exposed to a higher viral load. And there's been some suggestion, and this is the case in other infectious diseases, that a higher viral load can give you a more severe case of the disease. And there's also been talk about links with poor air quality and other environmental factors. So again, these may be contributing to people in BAME communities having more severe cases of the disease. And then there's this idea of how people from BAME communities are interacting with the health service. And there's anecdotal evidence of the kind of treatment of BAME communities by primary care, and particularly 111, being suboptimal, the 111 not understanding the cultural issues within the communities or advising people based on cultural biases that they have in their own heads. There's been some discussion about ambulance services going out to certain people and then telling them to stay home, and later those people being found dead in their homes. And this is something that's particularly been noted in the US, is that certain groups of people, particularly Black people, are more likely to have DNR statuses in hospitals, meaning that they're not resuscitated when they are in the hospital. So you can imagine that these also could be contributing to these excess deaths that we're seeing. And some of these factors, as we saw, were what we would think of as socioeconomic factors. And so what do we know about socioeconomic vulnerability in BAME communities? Well, here's the first thing. There's a very commonly used index that's used in England when we're looking at deprivation. It's called the Index of Multiple Deprivation. And this is the country split into 5 groups, going from the richest to the poorest. And the yellow bars show the white population. So you can see there's approximately a fifth of people in each of the groups, from the richest to the poorest group. There's slightly more in the richest than a fifth, and there's slightly less than a fifth in the poorest. And these are BAME communities. So you can see this massive gradient where there's a big concentration of BAME communities in the poorest areas in the country, and very underrepresentation of people from BAME communities in poorer areas. And what is this index of multiple deprivation? So it's made up of these 7 different elements: income, employment, education, health, crime, barriers to houses and services, and living environment. So here what I've done is I've plotted neighborhoods in the country. So these are LSOAs, kind of areas with approximately 1,500 people each. And on the y-axis is the proportion of population from BAME communities, and on the x-axis is deprivation. So as you see, these lines are all sloping upwards, suggesting that areas that are more deprived in any of these dimensions are more likely to be more ethnically diverse as well, right? And so you can see on every dimension of IMD, people from BAME communities tend to be living in more deprived areas. And particularly important for our discussion, I think, are the dimensions of income, employment, health, housing, and environment, right? So is there any correlation between deprivation and dying of COVID? Well, this is what the ONS says. And this is quite a striking graph. The gray bars show all deaths, and you can see the likelihood of dying from anything gets much worse as you're in a more and more deprived area. And the blue bars show COVID deaths, and you can see that even compared to the standard health inequality we see, COVID seems to be making things even worse and making that deprivation gradient even steeper. So yes, there is a big link between living in more deprived areas and dying more. So maybe this is explaining some of that gap that we're seeing. And so each of those dimensions of the index of multiple deprivation is underpinned by a whole bunch of different specific indicators. I've picked out a few just to give us a sense of what's going on. Again, I've got on the y-axis the percentage of the population from BAME communities, and on the x-axis it's kind of increasing in deprivation. And again, these dots are LSOAs, or neighborhoods in the country. So the first of these is showing overcrowded housing, and there's a huge gradient there. The next is showing number of people with disabilities and limiting illnesses, so the kind of people who claim benefits for disability. Here's air quality, so there's a massive gradient there again. Here's English language skills, so there's a small gradient here, and this may be something to do with the communication. I'm going to look a little bit more at this overcrowded household. So there's something called the English Housing Survey, which asks people how many people live in your house and how many bedrooms are there in your house. And do you have fewer bedrooms than needed to avoid undesirable sharing? So it's important to note this is not just a case of people wanting to live with their grandparents or people wanting, this is a case of undesirable sharing, people not being able to afford to live in houses big enough to contain their families. And I think things like the bedroom tax may have something to say here as well. So this is overcrowded households by ethnicity. So you can see 2% of white British people live in overcrowded households. 31% of Bangladeshis live in overcrowded households. 16% of Pakistanis, 15% of Black Africans, etc. And so, so you can see there's massive gradients in these overcrowded households. And let's just look a little bit more detail at who's living in these overcrowded households by age. So we said that these people, the really old people, those between 60 and 80, they're the ones really highly at risk. And so the blue bars show non-white British people. So 7% of those over 55 in non-white British ethnicities live in overcrowded households, and 4% of the 65 pluses, right? Compared to 1% of white British and less than 0.5% when we look at the over 65. So we can see that there's a lot of very high risk people living in very overcrowded households in non-white communities in the country. And these may well be the majority of people dying and making up those excess deaths. We can also look at the workforce who are working in precarious jobs. So remember we said that there's certain types of occupation where staying at home and not getting paid isn't feasible, and you're not going to be able to pay your rent and put food on the table if you're in one of these occupations, so you may have to be going out to work. And the kind of jobs we're thinking about are agency staff, people who are involuntary part-time workers, people who are in temp jobs, people on 0-hour contracts, okay? And you can see again, the blue bars are people from BAME communities, the yellow bars are people from the white community. This is data from the Labour Force Survey for the last quarter of 2018. And you can see in all of these categories, there's approximately double the number of people from BAME communities than from the white community. Looking a little bit more detailed at the particularly high-risk jobs, so you can imagine bus drivers, taxi drivers, the people making deliveries on the streets, people delivering your Amazon parcels, those kind of people. Who are they? Well, you can see 13% of them are Pakistani and Bangladeshi compared to 4% of them who are from the white community, right? So what does that mean? Does that mean that they are at higher risk? So this is what the ONS tells us. This black line here is the kind of average mortality rate for people, for men in the country. And this line here is for bus and coach drivers. This line here is for taxi cab and chauffeur. So you can see that these kind of occupations have massively increased risk versus the rest of us, which is unsurprising given the level of exposure they have to the disease. So the next thing to look at is, what if we start controlling for some of these socioeconomic and other factors? Is there still any residual impact on BAME communities, or is it all explained by these socioeconomic factors? So the ONS has done an excellent study that they've published recently, looking at individual level data. They've linked census records where they store ethnicity information and all sorts of other information about socioeconomic deprivation with the mortality records, looking at people who've died with COVID. And they've run a logistic model, and they've taken all the people who died with COVID, and they've taken a random sample, a random weighted sample of the population to compare them against, and they've run a statistical model. And they ran separate models for men and women, and they controlled for age, they controlled for IMD decile, so the index of multiple deprivation that we've been looking at. They controlled for household composition. They controlled for country of birth. They controlled for a bunch of other socioeconomic status variables, so education, jobs, whether you're renting or you own your home. and they controlled for self-reported health and having limiting health problems or disabilities. Okay, and they reported two main models. The first model they reported was a model where they just adjusted for age, and so this is like what we did when we saw those age standardized hospital deaths, right? And they ran the model for men and they ran the model for women, and they found that Black people are 4 times as likely to die of COVID than white people, and Bangladeshi and Pakistani people are 3.5 times as likely to die of COVID as white people, right? And this was the case whether it was men or women. So we know overall men are more likely to die than women, but when we just look at the inequalities within the men or within the women, we see that actually whether you're male or female, being Black or being Pakistani or Bangladeshi seems to be having equal kinds of effects on your excess deaths. And then here are the results from the fully controlled model, controlling for all of those things I told you about. And so even after you control for all of those things, Black people and Pakistani and Bangladeshi people are still almost 2 times as likely to die as white people from COVID-19 in England, right? So this is quite a shocking result. You'd expect that a lot of this inequality should be explained by socioeconomic factors, right? And looking a little bit more carefully at the ONS's report, you'll find these diagrams, okay? And these diagrams are a series of models they've run. So each bar represents a different model that they've run. The first model is just controlling for age. The next model is controlling for age and region and rurality, okay? So just controlling for where in the country you live and whether it's urban or rural. And then the next model is controlling for the previous 2 things and also IMD. The next model is all of those things plus household, then all of those things plus socioeconomic status, and then all of those things plus health. And the interesting thing here is that actually once you control for age and region, nothing else has a huge impact. I mean, in their careful statistical analysis, they do find controlling for all of these things gives you a better fit to the data than only controlling for age and region. But actually just controlling for age and geography seems to explain most of what's going on. So you can see that in the way that the difference between the yellow bar and these other bars doesn't really look very big, right? And you can see that when you look at the error bars on these, they all cross each other, okay? And there's this other interesting piece of data that's been recently published. Actually, it was published on the same day as the ONS study. So there's this big study called Open Safely, which is using a huge linked data set of GP records and hospital records. And it's a study run by Ben Goldacre's group at Oxford. And it looks at 17 million patients, and it controls for socioeconomic factors. It controls for a whole host of very detailed health factors and comorbidities. And even after controlling for all of those, because we may think, oh, maybe in the ONS study they didn't have detailed health data, they were only looking at self-reported health. But even after controlling for all of those things, they find that ethnicity has an independent effect of similar magnitude to what the ONS finds. So they find that Black people have 1.7 times and Asian people have 1.6 times the likelihood of dying of COVID as white people. And this is a very different data set, and only these 17 million people are mostly people from outside of London, from what I understood of their data set. But it's interesting to see that they're finding something very similar. Important to note that this is not yet peer-reviewed. This is something that's in the meta-archive at the moment and undergoing peer review. So there's some important things to think about when we're looking at these studies. The first is, what's the right results to be looking at? Should we be controlling for socioeconomic factors for all of these different things and then looking at differences? Or are these socioeconomic factors part of the story, and should we be looking at the uncontrolled results? And so is it the case that Black people are twice as likely to be dying, or should we be saying they're 4 times as likely to be dying because deprivation and the fact that they're working in poorer jobs and living in more deprived areas is not random, and there's something about the way society is structured that tells us that that's the case, right? So that's something to think about. And the other thing, the other kind of somewhat more puzzling thing is that ethnicity does not appear to be mediated through comorbidities or so of your social economic factors. And so actually it doesn't, I mean, it's almost like the first point doesn't matter too much for what we're saying, because actually from what we're seeing in the studies, the effect doesn't seem to be driven by that entirely. And so it seems to be that there's something else causing this residual BAME effect that we're seeing. And so it may be something, and this is over and above the things that we're controlling for, so over and above socioeconomic factors and comorbidities. It may be the case that based on ethnicity, people are being put more in frontline roles, or it may be something to do with cultural differences, which are giving them more exposure to the disease. Right? It may be that there's something on ethnic grounds that is making them more susceptible to more severe disease. So this could be something to do with them experiencing a higher allostatic load if they're suffering from a lifetime of discrimination. It could be something to do with vitamin D. I mean, this is something that's often touted as being a miracle cure to all ills. And there is a link between vitamin D levels and melanin levels or skin pigmentation. There could be something to be said about poorer interaction with the health service. So there could be some kind of, conscious or unconscious biases in some of the key interactions with 111, GPs, ambulances, hospitals, or there could be some kind of, again, a cultural reluctance to use the health service. And so these are all kind of open questions that we need to think about. And in thinking about them, there's a number of very tricky challenges. The first is death certificates do not record ethnicity. And so it's very difficult to get data on, deaths by ethnicity. And the ONS have done this heroic task of linking up census records to deaths, but it's a kind of a one-off effort. It's not something that allows us to monitor continuously what's going on. And ethnicity is not even always recorded on health records. So even when we're looking within things like NHS data, there's a lot of missing data on ethnicity. And so it's difficult to know what's going on in that missing data. Is it randomly missing, or is there more to it than that? And it's very hard to find ethnicity data in some of the other key administrative data sets. So when you're looking for causes and you're trying to explain what you're seeing, it's very difficult to do so because you can't link to other factors in other data sets. And there's already a trend where, what I'd call bad data science is used in many areas of policies to step in and fill data gaps. And often this is done by extrapolating societal prejudices and biases already implicitly encoded into administrative data. And so you can see areas like crime data where they find, there's more black people in jail, therefore black people are more likely to be criminals. And that completely absolves the kind of issues of institutional discrimination in the police service that have been so widely acknowledged. Right? And so it's important not to just jump in and use any old kind of data science methods to fill in the gaps. And so let's look a little bit more at these kind of the red and the blue factors that I'd highlighted on the previous slides. So we could think of some of these, the red ones, as kind of structural factors, right? And we can think of the blue ones as individual factors. The structural factors, things that as a society we are doing to put people at higher risk. And individual factors are things that you might say the people themselves are responsible for, right? And so one of the structural factors might be that there's people in more frontline roles and they're getting poorer public health advice, or advice that's not tailored to them. And on the other hand, you might say that cultural differences have resulted in some people not really isolating properly and ignoring isolation and carrying on doing things which are not helpful to the isolation. Or when we look at kind of biological factors, we might be thinking about higher allostatic load, which is something that, these kind of constant microaggressions create in people, versus something like vitamin D, which is something that is something that somebody could solve by taking supplements. And then, and we've seen this already in terms of the health service, it could be some kind of discrimination from the key health service organizations. And there was an interesting study run by ITV yesterday about discrimination within hospitals and how BAME staff perceived that they're treated. And this can be contrasted with the kind of individual factor of some people are just not willing to use the health service, right? And there's probably a mixture of things going on, and it's important not to use one set of factors ideologically to conveniently obscure the factors that you don't like. So one key research question is going to be, how do we unpick what's going on? How do we find causal effects in the data, the observational data we have, to figure out which of these things is going on? So here's an example, a really horrific example, demonstrating some of the structural issues that was in the news earlier this week. So there's a railway worker called Belly Mujinga who was working at London Victoria Station, and she was working on the platform, on the concourse, and she'd asked her bosses if she could be allowed to work in the ticket office because she's scared that she's got known respiratory problems, and she's scared that she's overexposed and she doesn't want to catch COVID, and she thinks she's higher risk. And her managers refused to allow her to work inside the ticket office, and they refused to give her any PPE to work outside. And while she was working outside on the platform, she was confronted by a man claiming to have coronavirus, who then went on and spat at her, saying that he has coronavirus, and he spat at her. And that happened on the 22nd of March, and tragically she died from COVID-19 on the 5th of April. And the fact that she was going out to work while the rest of us were in lockdown, and the fact that she wasn't able to or listened to by her manager, and the fact that she wasn't given PPE, and the fact that somebody felt that they should spit on her, all of these things boil down to some of those structural factors that we're talking about. And none of these things boil down to her vitamin D deficiency, or her culture, or her choices. Right? So it's important to think about. And then on the kind of other hand, there's a kind of individual narrative. And so this was a piece in the Telegraph last week as well, saying campaigners are twisting BAME COVID data to further their victimhood agenda. So structural issues from this perspective are seen as a victimhood agenda. And so here are some quotes. As it happens, as if this is kind of a random point, prior medical complications are not found in equal proportions in all ethnic groups. 73% of Black adults in England are overweight or obese. People classified as Black or South Asian have much higher rates of diabetes than the population as a whole, and older Pakistani men have particularly high levels of cardiovascular disease. These differences have no connection to discrimination. It's quite an interesting quote to reflect on. Do health inequalities have any connection to discrimination or not? And another quote from the same piece. Then there are cultural differences. South Asians are more likely to live in large households comprising 3 generations, thereby bringing vulnerable older people into more frequent contact with younger people who may carry the disease without realizing. These are lifestyle choices unrelated to discrimination. So overcrowded households are also lifestyle choices unrelated to discrimination, right? And then we can look at some of the science on vitamin D. So often, anytime anybody raises any kind of an issue around structural issues, the first response they'll get is, have you looked at the studies on vitamin D? So here's a systematic review of studies on vitamin D, looking at hundreds of, it's a review of reviews, so it's looking at hundreds of systematic reviews and meta-analyses, and its own review of observational studies and randomized trials. So it's an absolutely huge review, and it finds most of the studies in this area are poorly controlled and badly designed studies. And looking through all of these studies, they find no convincing evidence of a vitamin D effect. Not saying there isn't one, but just saying that it's not necessarily the silver bullet that's going to answer everything. On the other hand, you may be thinking, what if there was a handy pill that could deal with so many of those structural issues? Well, as it happens, a team at the University of Oxford have done this study saying this beta blocker, propranolol, reduces implicit negative racial bias. And what kind of a study is this? Well, this is actually a double-blind placebo-controlled RCT, the gold standard of what we would call a clinical study. And what did the study find? The study found that propranolol abolished implicit racial bias. So if you were going to reach for a pill to solve this problem, I would suggest that propranolol might be more successful than vitamin D based on the evidence that we have. So what has the government done? So the NHS England has released advice to all hospitals to consider BAME staff vulnerable and do what they need to do to protect these staff. Public Health England has launched an inquiry, notoriously advised by Trevor Phillips, to look into this issue of excess BAME deaths. And it's interesting to note who Public Health England have chosen to advise their inquiry. So Trevor Phillips was former chair of the Equalities and Human Rights Commission, and he has a history of leading inquiries that identify cultural deficit in ethnic minority communities and overlook structural issues. He's also currently suspended from the Labour Party over allegations of Islamophobia, and he currently works for a private sector firm that produces software for the police, which has been described as data-driven identification technologies and databases that can replicate racialized stereotypes and reinforce institutionalized prejudices. So he basically sells software to the police that tell them what kind of crimes you're likely to have committed based on your skin color. And he links your name to your skin color and then your skin color to the kind of crimes that he thinks that you've committed. So it would be unsurprising to see this inquiry reporting back citing those individual factors. And maybe even more importantly, given Trevor Phillips's standing amongst BAME communities, this is unlikely to answer those people who are feeling most hard done by the government's role in any excess BAME deaths. And these are the terms of reference for that inquiry. And I mean, it's quite clear here from this quote from the terms of reference. The review will not ascertain root causes of findings that are likely to be driven by complex interactions. So the scope of this inquiry, I think, is very clear from just looking at those terms of reference. So just to finish, here are a set of research questions that we might want to think about given this data. So maybe the most urgent of these is the first. What interventions exist to help mitigate these impacts in the immediate term? What can we do straight away to stop these excess BAME deaths from occurring? And related to that, is it possible to unpick the causal effects of the various individual and structural factors using the observational data available? Okay. And then maybe some more ambitious or important questions nonetheless are, what does the response to the disease, both in clinical terms and in economic terms, tell us about the implicit valuation of different lives? So what do I mean by that? And this is particularly pertinent as certain groups of people are being told to go back to work. What do the policy choices made so far reveal about the societal exchange rate between Black lives and white lives? How does this compare across countries and correlate with other social values? You know, we know Black lives matter, but how much do they matter compared to white lives? Another question, do people voluntarily take on uncompensated risk or must power dynamics be included in economic studies? And we can think about this in terms of the kind of studies that we often see as economists, things like value of statistical life and willingness to pay, where the risk that you take and the compensation that you take for that risk is a measure of the value of your life. Right? And so are bus drivers and social care workers and Uber drivers, are they compensated for the risks they're taking? Or is this a function of power dynamics that we don't really account for very well in economic studies? And finally, should we be considering less simplistic epidemiological and economic analysis in order to understand the impact of policies on health inequalities, rather than rolling out policies that exacerbate these inequalities? The models that we've been using to advise the government, the epidemiological models, the economic models deciding the methods of locking down, the methods of shielding people, who goes to work, who doesn't go to work, they're not very sophisticated, and they may work for the average person, but they're certainly not taking into account what's happening to the people who are most vulnerable from this disease.